Hello guys, welcome to the Parson series, and this is part 4 of chapter number 8. Now I have gone a little short in these series now because this is your clinical examination part, and I would like you to see and go through one clinical examination daily. Now I know that your exams are coming very near, but I will sincerely say that it will be a good idea that you do this one series daily just before going to the bed. Now this will help you in two ways. Number one, even if you have not read the textbook, you will get the advantage of reading the textbook here, and secondly, if you have already read it, it will give you a quick refreshment and revision of the crisp topic, because clinical examination is really important nowadays. Okay, so last time we had seen the kinetic perimetry. We have already done. Today we'll be starting with the static perimetry. Static perimetry, it is usually done with the computerized automated perimeters, right? Now first we start with the automated perimeters. Automated perimetry actually has made the life quite simpler and easier because everything is computerized there. Okay, so what we are doing here, we are doing this examination simply more accessible as well as more reproducible. Now this I think is the most important aspect, because it has to be reproducible. Because every time, every time the patient is coming, the attending technician or optometrist or the ophthalmologist, the resident, anything may not be the same. So the quite reproducible results are very much required from the perimetry, and it has therefore a major screening, diagnostic and review modality in the patients having any visual field defect. So this could be a direct question also, that it is actually the automated perimetry. This automated perimetry has become the major screening, diagnostic and review modality in the patients who are having any kind of the visual field defect. Okay. Now automated perimetry has advantages over the manual ways. Let's see what are the advantages they are talking about. Number one, points in the visual field. The points that we are testing in the visual field, they are tested randomly so that the subject cannot anticipate where the next stimulus will be presented. So it's very genuine and reliable, because you are not getting any apprehension, any clue that from where the next stimulus will go. Number two is the visual field is tested by a static method. So here we are using a static method which quantifies a retinal sensitivity, and it is more accurate than manual perimetry. So it is more specific also, more diagnostic, more reliable, more accurate. Okay, you are not giving any clue from where the next stimulus is going to come. Then examiner bias, obviously it's not manual, so examiner bias is eliminated, and there is also constant monitoring of fixation. When we are doing the perimetry, one major issue that we face is constant monitoring of fixation. So here there is a constant monitoring of fixation by itself. Okay. Then abnormal points are retested automatically. Now obviously if we are doing the manual perimetry, I would like to retest those points which gave me the abnormal results. Here it is done automatically. Then built-in custom-made programs can be selected, and further programming can be done to perform the customized visual field testing. Okay, so there are many advantages of this automated perimetry over the manual perimetry. Now there are various test programs available, like the Humphreys field analyzer. As we have talked it before also, that nowadays this Humphreys field analyzer perimetry has become the standard. Okay, on one hand we have got the threshold test, on another hand we have got the extent of the visual field and how many points we are testing. So look at these. One is your 10-2, so this is giving you 10 degree, and we have got 68 grid program. Then we have got 24-2, this is 24 degree. Okay, so one thing you have to see, that whatever number is written there, that is the amount of visual field in degrees. So if it is 32, then it is 30 degree. Okay, then 60 is from 30 to 60 degree, and full field is 120 degree. Now looking at the points, okay, points may vary, like here we have got 68.54, 76, 60, 14 like this, but the degree can be known from the threshold test only, from the name itself. Now each of these could be done using the different strategies. So I would say the name of the strategies is a must for you people. You should know what it is all about and where these strategies are used about them. Okay, so one is your what you called as the supra threshold static perimetry, and then we also have the threshold perimetry. Supra threshold. Now what is this? Supra threshold it uses the stimuli readily visible to the normal controls. So this is actually supra threshold, means they are using that stimulus which is readily visible to the normal people, normal controls, okay, and these are presented at selected locations throughout the visual field. Now the machine will record these locations where the target is seen and where target is not seen. This quickly screens the visual field for any of the gross anomalies, and if the stimulus is not visible in any area, further evaluation should be done. So simple, we can use it. We are showing that stimuli which is readily visible to the controls, and then so many points are selected randomly where the target will be shown to the patient, and it will record where the target is seen, where it is not seen, and it will quickly pick up the gross anomalies. This was your supra threshold. Now the other one is your threshold perimetry. Threshold perimetry is actually recording the incremental threshold measurements at different visual fields locations, typically arranged in the grid pattern or along the meridians. Now this is giving you the stimulus in increasing thresholds at the different locations, and these different points are actually scattered either in the grid pattern or in the different meridians. Okay, now static perimetry, when we are talking about this, performs a sampling of 50 to 100 locations which is commonly affected in the ocular pathologies, and a staircase threshold determination strategy or a bracketing technique is used to measure the threshold values at each location. So the strategy that we are using here, this is called as the staircase threshold determination strategy or the bracketing technique. The light intensity is increased in large steps. Now what do you mean by staircase? So we are increasing the threshold intensities in a staircase kind of a pattern, in a regular pattern. We are increasing them side by side. This is your large steps till it is perceived by the patient, and then it is decreased in smaller steps to the point where it cannot be identified. So we are going that way, increasing, and then we are coming down. That is your staircase pattern. The threshold sensitivity. The threshold sensitivity measurement recorded at a given point indicate that this stimulus can be perceived by 50% by the patient 50% of the time. So if I am demarcating the threshold sensitivity of the patient, what does it shows? It shows that the stimulus will be perceived, okay, by this patient at least 50% of the times, then it becomes its threshold sensitivity. The strategy that is most commonly used now, the strategy that is most commonly used is your SITA. If you remember, this is your Swedish interactive threshold algorithm. This is SITA, very, very important, okay, and this is actually two predetermined values for each of the locus tested. So whichever loci you are actually testing, we have got two values, predetermined values. One will be for the glaucomatous eye and one for your age mesh normal. So what are these two values? One which should be there in the eye which is having the glaucoma, and one that is present in the eye which is normal, age control. Okay, depending upon the patient's response, we will be analyzing the functions. The patient is seated, okay, and with his head at the center of the illuminated sphere. The appropriate corrective lens is placed in front of the eye to be examined, and the other eye is occluded. Now this I told you in the beginning also that for doing any of the testing and examination in the eye, it's very, very important that you are occluding the other eye, because there is no point of testing the eye when both eyes are open. Each eye has to be tested individually, so you have to occlude the other eye. Second important thing is that always you have to give the corrective lens in front of the eye that is to be tested, because maybe the person's vision is not appropriately corrected, and that is why he may not get the adequate response on the perimetry. So that is again very, very important. The patient is instructed properly, because this is subjective. It depends upon the patient's response. So patient's cooperation, level of understanding, and somewhere the IQ or the how much he is able to understand, that is very much required. And he has to be instructed to maintain the constant fixation at a specific target, and he has to actually press a button there whenever he perceives a light stimulus. And sometimes what happens that though they may have seen it, but they may fall late in pressing the button, so that will also be missed. Okay, so they have to be very, very careful, and whenever they see the stimulus, they have to just press that button. A computer randomly will present the stimuli of varying luminance. When we are using the static perimetry, we are using the different degrees and intensities of the luminance at the different locations. The threshold values of an individual are then compared by the computer to age meshed normal values, and whatever values we are getting, then computer will analyze it with the age meshed control value, and then it will be giving you a final result. Abnormal areas together with the density of the visual field defect, these will be computed. The comparisons are shown in the numerical form, box plots, a grayscale. So I'll show you that. The total deviation box plot presents one of a group of symbols at each of the location tested, indicating whether the sensitivity there is with age adjusted normal limits, or it has a probability of being seen in less than 5%, 2%, 1%, 0.5%. So actually what it is doing, it is testing, and then it is comparing it with the controls, and it is telling you that how normal or how abnormal the values of this patient is, like the probability of these values, okay, being present in the age meshed normal persons, whether it will be 2%, 5%, something like this, so that you get to know that how much is the problem in that person. Okay, now this provides an immediate graphical representation of the locations that were abnormal, okay, and you get a pattern deviation plot. So this is there, this will use your community medicine, okay, shows the sensitivity levels after the average or the overall sensitivity loss that has been subtracted. Now suppose you get that the deficit that you are getting, that is predominantly localized in one particular area, the total and the pattern deviation plots look virtually identical. So if you can take it as other way around also, that if you are getting the pattern deviation plots, okay, the total pattern deviation plot as well as the pattern deviation plots, if they are looking identical, that means the visual field defect is localized in one area. However, if the loss is widespread, as in the presence of a cataract, abnormalities on the total deviation plot appear on the total deviation plot, but the pattern deviation plot is virtually normal. So this is common sense also. If the visual field defect is localized, you will get it on total deviation plot also and pattern deviation plot also. But if I am having a widespread one, so that in the total it will come, but in the pattern it won't come. On the grayscale, the areas of high sensitivity near the peak of the hill vision are denoted by a lighter hue, and the areas of low sensitivity by a darker tone. So wherever you are getting, the lighter tone, that is your high sensitivity areas, and wherever you are getting the low sensitivity, that will be given by the darker tone. Okay. Now see, this is the sitting arrangement of the patient. Okay, now what is most likely to be expected at your level is that you should be able to identify this instrument. You should be able to tell the basic things, what is perimetry, what is a perimeter, what are the types of perimetry, what is the difference between static perimetry and the kinetic perimetry, which one is better, which do you use for glaucoma more commonly, which do you use for neuro-ophthalmology more commonly, and what are the different kind of plots. And then what is the most important commonly used strategy, then what are the things that you have to explain to the patient, because they are asking you the basic clinical things, just simple things. How will you ask the patient to sit? He has to be seated, he has to keep his chin in this Can you see this bowel kind of a thing? And the forehead along the this headrest should be there. He has to constantly watch at the point of fixation, and you know, the lights should be dim, and he has to press that buzzer. How you are going to get the plot? So all these basic things you are being asked apart from the image to identify. So see, this is your plot. And you are getting the areas of low sensitivity and the higher sensitivity. Can you see here? We have got the lighter denotions as well as the darker tones. And can you see, this is giving you the central demarcation. So it is giving you the information up to the 30 degree. And what is this? This is your blind spot. Now always remember that how will you come to know that which side eye it is? Which side eye? So blind spot is always lying in the temporal field. It is lying always in the temporal field. Why it is lying in the temporal field? Because blind spot represents the optic disc, and optic disc lies in the nasal retina, and we know that the nasal retina will always correspond to the temporal visual field. So if this is the blind spot, okay, this is lying on the right side, therefore this will be your right eye. So whichever side you are seeing the blind spot, that eye it will become. So it is very, very simple. Okay. So here is your total deviation map. This one is your total deviation map, and these are your pattern deviation maps. And as I told you that if both of them are looking similar, that means there is some localized visual field defect, okay, that is there. Now the automated perimeters, like we have got the Humphreys field analyzer and the octopus. Now indirectly you have got the names of two automated perimeters. They could be asked. One is your Humphrey field analyzer and one is your octopus. They provide a summary of the statistical analysis of the plotted visual field. This is called as the visual field indices. The mean deviation on the Humphreys field analyzer, or whatever is the mean defect that you are getting on the octopus, it is actually sorry, it is the average deviation of sensitivity at each test location from age adjusted normal population value. So this we have already seen that what information actually I am getting. I am getting the average deviation of the sensitivity at each tested location as compared to the normal controls of the corresponding age. Okay, it indicates a degree of generalized or the widespread loss of the visual field. The pattern deviation. So if I am talking about the pattern standard deviation on the Humphreys field analyzer or the loss variance on the octopus, it is the calculation of average deviation of individual visual field sensitivity from the normal slope of the visual field after correcting for any overall sensitivity differences. So what it is doing, why it is actually called as automated, because on itself it is taking up your patient sensitivity testing points, then it is comparing it with the age met controls, and then it is giving you the average deviation from the normal and how much it is deviating, 5%, 2%, 3%, something like this. So this is a measure of localized visual field loss or the scotoma or scotometer. Now another thing is your corrected pattern standard deviation. This corrected pattern standard deviation and the corrected loss variance take into account the short-term fluctuations which can be exhibited by the patient, and these are actually derived when you are having at least 10 locations twice to determine the average deviation of repeated measures. So when I want to calculate the short-term fluctuations in the patient, I will require more of locations. So when we want to just calculate the average deviation, I am taking less of locations, approximately half of these locations, and when I have to just check the fluctuations, and I am using more of the locations. This reduces the effect of intra-test variability in the patient responses. So obviously if you want to decrease the variability, you have to increase the number of testings. Charting of the visual field is useful in the diagnosis of many conditions. So let us see the importance of this visual field examination. It is helpful in glaucoma, neurological disorders, retinal diseases, retinitis pigmentosa, and following the laser treatment of diabetic retinopathy. So we always think about glaucoma whenever we say perimetry, but you have to do it in cases of neurological disorders, because there also you have got the visual field effects. Then we have retinitis pigmentosa. ERG is the best test for the retinitis pigmentosa, but obviously there is a peripheral visual field constriction, so there also you can use it. Then if you remember, we also have a ring scotoma after giving the PRP in cases of diabetic retinopathy. So because you are giving so many spots, how many spots were there? 2000 to 3000 spots. So that time also you may require this. Kinetic perimetry with a Goldman perimeter is useful in detecting the neurological defects, because it is giving you the quick assessment of both central and peripheral fields, a very, very important thing. So when we are doing the perimetry for the glaucoma, it is actually the static perimetry which is more important with the Humphreys field analyzer. But when we are more interested in the neurological defects, then we are using the kinetic perimetry by the Goldman's perimeter. In some countries, the visual standard for driving includes the documentation of 120-degree extent. So even some of the countries, advanced countries, they are asking for the central 120 degrees of the visual field when you are asking them the driving license and all. This is plotted with both the eyes open using a special program on the Humphreys field analyzer. Now this is again important, because I think this is one of the exceptions where you are taking the visual field plot with both the eyes open. Alright, significant change in the visual fields over the time can be computed by various programs available, but it is sometimes not possible to distinguish between the subtle visual field changes from the long-term variations. So this completes your perimetry. I think a very, very important and a high-yield topic. Okay, go through the perimetry, definitely try to see what is the difference between static perimetry, the kinetic perimetry, how actually you read the plot, what are the general instructions, where it is used, and what is the basic principle. That's all. Don't go in much of the details after it. I know when you are reading these kind of things, you have a lot of questions in your mind, because the topic is not complete with this much of information. There are so many things, but you know, you have to limit yourself up to a certain level, because you have to read all the 19 subjects. Okay, when you start with your ophthalmology residency, then there is a no limit. Then you can read to any limit about this technique, but I would say that here you should limit yourself, because you know, inquisitiveness is always good, but you know, we have a limitation of time and you have to complete the course. So limit yourself up to this, and if you have any queries, obviously you can ask me in the comment section, and it is highly advisable that you write it in the comment section under the video, whatever doubts you have, so that I get to know that you are seeing the video. Because you know, I'm highly recommend the reading of Parsons, and that's why I'm taking so much of efforts to teach you the Parsons. So I hope this you will like this video, and you will share this video with your colleagues also. Thank you, and happy ophthalmology.